Morning, everyone. Thank you so much for joining us today for the NEMSIS TAC November public webinar. Today is Thursday, November 15, 2018, and today we're going to learn about the 2017 public release data set, which features version 3.4.0 data. We also have this morning Dr. Clay Mann, who is the principal investigator with the NEMSIS Technical Assistance Center, who will be conducting the training this morning. Please feel free to ask questions either through the chat box or directly. Thank you for your time, and we're going to go ahead and turn the time over to Clay Mann.
All right, thank you, Monet, and thank you, everyone, for joining. This is actually a presentation we look forward to giving every year as we complete a national data set based on NEMSIS. That's always really a time to celebrate really the NEMSIS system, collecting data at the local level, passing it through our states and up to the national level to provide an opportunity for research is just a one-of-a-kind healthcare data set in this country. So I'm always incredibly happy when we have the opportunity to close a data set. I'll begin by letting folks know, those who have been on the V3 implementation calls and on the DMC calls, we have not yet released the 2017 data set. That's late in the year. We had it ready to go on time, but as we were cleaning the data, we noticed that one of our mappings that was moving version 3.3.4 data into a 3.4.0 translation, and so that the entire data set would be at 3.4, there was a problem. And so we went back and it had about 3.5 million records that we had to reprocess to correct that, and that has now been done. We're just correcting the data, so it's close to release, but not quite out yet. So I imagine just in the next couple of weeks we'll have it available. But we certainly can talk about it today, let's move forward. I'm going to take a little bit of a different approach today. In the past, we've talked about the size of the data set, how many cardiac arrests were included, strokes, kind of a description of the types of calls, time-sensitive calls, the number of calls that resulted in a patient contact and transport, that kind of thing. What I thought we would do today is maybe take a little bit of a different approach and maybe talk about the value of version 3 data. This is the first public release data set where we have fully version 3 data. So let's take a hard look and see if the data is actually can stand up to the expectations that were associated with version 3. So we'll talk about that more in just a minute. What I did want to talk about perhaps is just the research that was done this year on the using the NEMSIS national data set. So, of course, all this research is still done under version 2 since we haven't released a version 3 data set yet. But I did just go into Google Scholar yesterday and looked at the number of scholarly articles that have been produced using NEMSIS data. You can see the all-time figure is 793, almost 800 articles. For this year, if you just limit Google Scholar to this year, you can see we have 76 articles that have been published. You can see some of the titles here. I just quickly grabbed some titles off of Google Scholar. I've read through the bulk of these. There are really some standouts. I think the article that was looking at the underutilization of glucagon in the pre-hospital setting was a really valuable article. The two articles having to do with diabetes and hypoglycemia that are listed at the bottom of the page here, those are two really well-done articles that really describe, when you take the differences between those two and the synergies, it really does a great job of characterizing the care that we're offering in the pre-hospital setting for these patients. So that was another really powerful article. Pre-hospital pain management and disparity by age and race listed here. Another really good article that helps us understand the importance of pediatric pain management. So really some great articles were published this year. There were a couple of standouts. Just going to point to a couple of them that I think were really valuable. So here's an email I received from Ash, Dr. Panchal, who is the Research and Fellowship Director at the National Registry of EMTs. He worked with folks at the CDC, and at NHTSA to develop an article that was published as an MMWR that came out just a couple of months ago. And he provided a nice comment indicating that altmetrics, which is probably the most popular way of tracking the influence of research right now, listed this article in their top 99th percentile for the studies that they were currently reviewing, and turned out to have a reach that was in the top 5% of all research that's ever been tracked by altmetrics. So clearly naloxone administration is an important topic, and clearly NEMSIS data is contributing greatly to that work. So this was just a great standout article that's worth mentioning. The other one I'll just mention real quickly that isn't even published yet. It's been accepted for publication in JAMA Surgery, but it's going to be another just really important article, I think, that just smacks of the great value that's coming out of the NEMSIS project. So the title of this manuscript is The Relationship Between Emergency Medical Services Response Time and Motor Vehicle Crash Mortality, an analysis of data from 2,268 counties in the U.S. So again, the power of having a census-based data set rather than a probabilistic data set where we're really trying to capture the entire country allows articles like this to be done on over 2,000 counties in our country. These investigators linked the NEMSIS data to FARS data, which is the Fatal Outcomes Crash Registry. And so this is a registry that's maintained on people who die in crashes. The study is based on over 2 million EMS responses to a motor vehicle crash. And when this is published, I've had a chance to read through an early draft of this. But the real value of this article is there has just been that for decades that argument about how important response time is for time-sensitive issues, and we kind of go back and forth in regards to the value, because really the most linear approach to reducing response times is putting more resources out on the street, and of course that can be difficult. So we have at times downplayed the importance of response time, and other times we talk about its value. All of it has been based on really city-specific studies or maybe a state-specific study. Here we really have a very comprehensive study that will show in this country the increase in mortality from motor vehicle crashes for every additional minute that is required for a response, for EMS to arrive. So it will really lay to rest any kind of conversations about whether this is an important topic or a non-important topic when you start thinking about response times. It will now provide the actual truth, right? We'll know what you can expect in your community for every additional minute of response based on 2 million EMS responses in 2,000 counties in the U.S. So again, it just really provides incredibly valuable information for us to be able to improve the care that we offer to our citizens. And so look for that article. It should be out soon. I just want to remind folks, lastly, of the ways that you can access NEMSIS data. You can request the data right on our website, nemsis.org. So it's made available to you free of charge. We work with you to make sure that you're using the data correctly, and if there's ways that we can aggregate or mask some elements to improve your ability to answer a hypothesis, we work with you in that regard. And then also, folks know about the EMS Data Explorer. This is kind of an OLAP Cube type of a tool. It's the one here on your left, and then there's also Tableau reports. Much of the version 2 data from NEMSIS can be found in the EMS Data Explorer. So if you go on the website and you access this, you'll have access to 43 million EMS activations from 3 years, 2004, 2005, and 2014, 15, and 16. And just to kind of show the power of this, I just looked up the number of events we have where naloxone was given. And you can see among, because that's an important topic, I think, right now in the literature and in our healthcare discussions in communities. You'll notice that we have almost 500,000 naloxone administrations in this data set that you can look at in relationship to other care that's offered, the type of patient, the type of provider giving the naloxone. And then, as we're going to be talking about today, we have been moving as an industry to version 3 of NEMSIS last year and this year. This year is the first full year of version 3 data. Our tools that are going to be demonstrating version 3 data is Tableau, and so here is kind of just a snapshot of the public naloxone dashboard that's also available on the website. And you can see here, as we bone up with the number of agencies and states that are coming onto version 3, we so far have collected 170 EMS activations where naloxone was given. And that naloxone was given by 3,541 agencies in 43 states and territories based on that version 3 data. So these are the mechanisms we're using to share the data with your stakeholders and at your state levels. Please feel like you can come to us with questions at any time if you have questions about how to use those tools. We'd love to help. All right, well, let's go ahead and start talking about the 2017 data release. So I just bring up this table that I kind of maintain just to show you the growth of NEMSIS over time. These are the number of EMS activations that reside in the National Repository by year, the number of reporting states, the states that were submitting data, the number of agencies that reported to the National Repository, the resulting number of events, so these are EMS activations, and then you can look at the subset of those that actually included the treatment and transport of a patient based on a 911 call. And you can see that we had just great growth as we're coming, bringing NEMSIS up and bringing folks onto version 2 until we kind of got to the point that we were really representing almost 90% of the entire country in 2015 and 2016 with near 30 million records in our repository. 2017 is our first version 3 only data set, and so you can see that data set that will be available will include data from 36 states, 4,000 reporting agencies, almost 8 million events in the registry, and just over half of those include a patient that was treated and transported based on a 911 call. So you can see there is clearly a transition as states move from version 2 to version 3. I'll tell you the growth is exponential, so far we collect near real-time data, as folks know, into our repository. So right now, as of yesterday for 2018, we have over really close to 19 million records for 2018. We'll hit 20 million to close 2018. So we'll go from 4 to 20 million. So just great exponential growth. I mean, if we were to double that again, we'd be done. We'd have the entire country. So states are working incredibly hard. Agencies are making the move. And the data set continues to grow and to be incredibly valuable. All right, well, I talked about the idea maybe of concentrating this presentation not so much on describing that 8 million records, but let's take a look at, for the first time, whether or not our V3 data is meeting the promises that were associated with NEMSIS version 3. I think we have someone who could mute their phone. We have some background noise, if you'd be so kind. Yeah, thank you. So there were basically 4 promises associated with NEMSIS version 3, 4 real improvements we were hoping to accomplish comparing the version 2 structure of NEMSIS compared to this new idea that was brought forth with version 3. One was improved data quality. This was going to happen because we improved the data structure of the underlying data set, and we also included business intelligence, so over 450 business rules that resided within a schematron file that had to be run with every record. That was a national standard. There were a few elements that were added with the promise of enhancing our ability to look at provider performance and protocol adherence. Data submission, rather than being quarterly, or many states only submitted their data once a year under version 2. With version 3, data transfer would be automated and should be real time. And then, of course, we became ANSI compliant as a standard, and so we had to utilize national standards for many of our elements. That's been kind of a mixed bag of some benefit and not so much benefit, and we'll talk about that in greater detail. All right, so let's march through each of these and see if we're really meeting our goal that we hope to accomplish moving from version 2 to version 3. Let's talk about improved data quality. So I'm just going to begin by showing this chart that we just finished yesterday. This is really kind of a simplistic tracking that we've been using all the way since 2010. We've published this chart every year since 2010, just tracking different types of elements that have been in NEMSIS. So some things like the dark blue line here, patient sex, we kind of expected that would always be close to a 100% valid values. EMS is used to collecting it even when it was paper files, and of course it's an easily distinguishable element. So you can see the y-axis here is percent of valid values, and then the x-axis is time. So we tracked patient sex just to set the bar, right? We'd like all of the NEMSIS data to be this complete. The other one that's very high is this light blue line is valid EMS response times. We've always got good times in the NEMSIS data set. That just speaks to the fact that it's an element that EMS is very used to collecting. It's a traditional element. Some of these, though, really, it took a while for EMS to recognize the value of collecting. So one is transport mode from the scene. That was always above 90%. But you'll see in 2016, moving now to version 3 and requiring these business rules be present, you can see that has brought the percent accurate with valid values from about 92% now up to 100%, because there's a business rule that requires that you indicate the transport mode from the scene. So the same is true for some of these others. So complaint reported by dispatch is this checked and dashed line. You can see version 3 is just really increasing the number of valid values in the records. Then there were these two that were a little bit logical, right? So the red line is, if you indicated yes, that there was a possible injury, did you report the injury mechanism? So you can see in 2010, only about 70% of the EMS activations where we indicated there was a possible injury, did they report the mechanism? And you can see that's been getting better as our states have been working with our providers. And in 2016, we added the business rule that says if you've indicated there's an injury, you need to indicate what was the cause of that injury. And so you can see that steep incline. The same was true of cardiac arrest etiology, right? So if you indicate in ERS 01 that there is a cardiac arrest, either before or after EMS arrived, what was the etiology? What do you think is the etiology of that arrest? Was it respiratory? Was it cardiac arrest? Was it trauma? And you can see that we had, even in 2011, below 50% of our cardiac arrest indicating etiology. Folks have been getting a lot better. And, of course, in 2006, with the addition of business rules, it's in the high 90s. So, yes, I would say if you look here at 2016, the addition of these business rules into NEMSIS is going to greatly increase the quality of the data that we're getting from our providers. Then I also just took a snapshot yesterday just of the submission dashboard. All the states can see this same diagram for their state. I just ran it for the nation. And so you can look here and you can see the number of records that we're receiving per day. As many as 100,000. We've received 200,000 records in a day. Some days are lighter, 30,000 records in a day or 25,000. These here in red are the number of records that are sent to us via web services that are rejected. We have a rejection rate of about 1 to 2%. And so that's small, but we continue to work with the vendors to improve that. What I wanted to show you here was two things. So if you go down into this lower bar chart, you'll see among the records that we have accepted and processed, those in green had no warnings, so none of the 450 plus business rules were triggered. Those records that did trigger at least one warning are here in orange. Well, if you look at the average number of violations or warnings that are occurring per record, it's really only about one. So even though we're triggering some of those 450 business rules, each record is really only triggering about one of those. And if you look at which of the rules are being triggered, you'll see that over 50% of the time, so among over 500,000 records, which is represented here, there's about 500,000 records here, that over half of them, 0.5, had this as its single violation. So when you indicate that you're taking a patient to a hospital or a freestanding emergency department, please report the capability of that hospital. This has been the one rule that is causing most of the triggers, and so most of the violations. This is a rule we're going to reevaluate for 3.5, but clearly it's the rule that keeps this from being almost all green, right? So our data quality is really, I think, much improved under version 3. All right, so I'm gonna stop there before we move on to looking at enhanced provider performance, being able to look at performance. Any questions about what we're looking at in regards to the quality of the data coming in version 3?
I have a comment on the hospital capability. This is Melissa.
Oh, yeah, Melissa. Yeah, please.
I think we talked about this maybe on the national element work group about demoting hospital capability, but working with my vendors, I know that the reason when that element is completed, it is autofilled based on what's in the demographic data set.
Right, for each hospital.
So even if you look at what's completed, most of them are going to say general hospital because it's defaulted to that, or to be autofilled as that, and so the provider isn't actually choosing it.
Right. Yeah, thanks for bringing that up. Actually, there is a process in place, and it's not being used correctly. So that's the conversation that I think needs to happen for 3.5, and why it was discussed to drop it. Is there is a mechanism in the demographic section to assign capabilities to all hospitals that are listed in the state data set, and then just have it auto-populate. If you say you're going to St. Mary's, then it automatically knows it's a level 3 trauma center and a PCI certified hospital. Those would be there automatically, and so the providers didn't need to report it. If they're all going in as general hospital from the demographic section, then that just kind of speaks to the idea that they haven't been added. But it's your point's well taken, Melissa.
Yeah, but also, even if it's being auto-filled trauma center, I don't think there's any BI in the software that's looking at it's evaluating the impression or the cause of injury and saying, oh, well, the reason why they're going there is because of that injury or that impression. So I don't think it's possible to autofill it based on the reason why it was selected.
Right. So I think I'll look. I think it's a one-to-many. So I think you can indicate all the types of certifications. But you're right. If it's a severe trauma and it lists 3 different types of certifications, only one dealing with trauma, you'd have to make the assumption that they're going there because it's a level 2 trauma center, not a PCI certified hospital or something.
I think it's a one-to-one.
Oh, okay. Okay.
Yeah.
Okay, fantastic. Yeah, so so those are the kind of conversations we need to have related to version 3. NHTSA is reviewing the recommendation to remove this element as national, so that's kind of a different conversation, but really important to discuss, and maybe why this is an element that is so hard to complete correctly. Yeah, thanks, Melissa. Very helpful. Other comments about data quality in version 3? Great. Okay. Great. All right. Let's talk about the promise of version 3 to be able to enhance our ability to look at provider performance and protocol adherence. This is a little bit early in the stages for us at the national level to be able to decide whether this is actually improving and whether version 3 is helping in this regard. Almost all of the additional elements from version 2 to version 3 were related to this topic. I don't really have any data at a national level related to this. States could speak to it. I would just point out that we have the Performance Measures API that's currently in beta form and was just evaluated by a number of vendors that will help us to be able to enhance performance with version 3 by providing benchmark data to agencies using national benchmarks. So that's under development. I think we'll have some good information regarding whether or not we're doing a good job of enhancing our ability to look at performance in the near future. The Performance Measures API is scheduled to be released in December, the end of December, early January. It was out in beta form, and some great comments were provided, so we're making some adjustments to the web services to ensure that it works well for our vendors. So that's one that's a little hard to look at on a national level. Let's look at the promise of V3 being able to deliver to our states and to agencies and the public reports based on timely data. So can we transfer data in real time? So we always kind of advertise that if we're working directly with an agency and we're on the phone and they close a record in someone's living room in Fargo and it passes through the state repository and lands in our national repository in about 7 minutes, and that's been consistent whenever we work with vendors to bring them up. But what's actually happening with the data? So here at the bottom of this report that you receive as a state, those state data managers, you'll see different times here. But this is what's happening at the national level. So we receive about 25% of our records from the time that the record indicates that it's closed until the time that we receive it. From the time the record is opened until the time that we receive it in our repository is about 2 days. And you can see for 50% of the records, it goes up to 204 hours. This these numbers remain skewed because, of course, states are still coming onto version 3. And when they do that, we allow them to backlog data to us since the beginning of the year. So we had 2 states that just came on last month, and they have been sending records that occurred very early this year. So these numbers at the national level will remain kind of skewed until all of the back data and all the states are on. But you can look here for your own state and see what your lag is in regards to how concurrent the data is. We refresh the Tableau reports every 2 days, so there's also a lag there. We're moving to refreshing these every day, and so we're also building our infrastructure to ensure that you at the state level and for the public reports can have very timely data. But that's kind of where we stand right now in regards to the timeliness of data. So really, we've gone from quarterly or yearly submissions to data being current at about 2 days, 2 to 4 days, depending on for you to actually see it. So any any questions on timeliness? Yeah, sorry, I think I interrupted somebody. I apologize. Okay, all right. All right, the last topic, and probably the most important one that we're still attempting to tweak with 3.5, and we've talked a lot about this with the data managers, is this idea of becoming an ANSI standard. We are now an ANSI standard. It's approved through HL7, Health Level 7, and we had to synchronize with clinical content. What this meant is many of our elements became more precise, and under the model that was developed for 3.3.4 and 3.4.0, the number of values that were available for some elements greatly increased. And so what you'll see here is many of the values that are reported here for these elements are either SNOMED codes, RX norm codes, or ICD-10 codes. There's some LOINC codes here, but what I'm showing you is just the number of values that were available in version 2.2.1, and then now the number of values we see in the 2017 data set using these national clinical data sets. So in version 2.2.1, both procedures and medications, there was not a set list. It was a text field. And then we had some black box logic here that would take a text term and would categorize it into like terms. And so we, over about a decade, we developed kind of a fuzzy logic process that came up with 122 procedures. In version 3.4 in 2017, we reported 598 procedures. Medications actually went down comparing version 2 to version 3. We had 1,300 medications in version 2. Converting texts, though that dropped to 929 using RX norm codes. And that happened because there were, we allowed different terms for the same medication in some situations. Also for things like hypoglycemia and things, EMS may report that they gave the patient, I don't know, a popsicle or something to help the patient. That can't be recorded as an RX norm code. So those are maybe some of the reasons why those went down. Then you'll see the other 3 categories. We've just had these exponential growth. So the number of cause of injuries in version 2 was 31. That's gone to 1,300. Symptoms 21. Now we have 1,700. Impressions is the worst. We went from 27 primary and secondary impressions for the call up to 4,500. So what do we do with this is the current issue we're wrestling with. There is this question of, value and relevance versus precision, right? So clearly cause of injury is now much more precise, right? We went from 31 classifications that were very generic to 1,300. But, you know, here's some examples, right? So we have actually 14 patients in the 2017 data set who were occupants in a spacecraft that caused an injury. We have a person bitten by an orca and struck by a duck, and there's just lots of specificity in the current codes. And so, is that specificity needed? Of course, it would be almost impossible to be able to determine if these are valid codes, right? I mean, I don't know what happens at Cape Canaveral. I guess that's in Florida, and in Texas maybe there were some spacecraft injuries. I don't know, but it's just very specific. And here's kind of another example here, the lower part of the screen, where we're just looking at codes that have a stem of W05. So this is kind of wheelchair injuries. And you can see that really there's no recognizable difference, at least for EMS, as far as EMS is concerned, among these 6 categories. They're all really falls from a non-moving wheelchair or scooter. That's where maybe we have to decide: are we interested in looking at wheelchair versus scooter, or are we just interested in looking at mobility devices, right? So can we collapse it? So that's the work we're doing right now, trying to see if we can reduce these number of categories. Maybe as an example of this, I'll just bring up an Excel spreadsheet that we've been working with. Some folks have seen this, but I think it's valuable. So here we've taken all these 1,300 cause of injury codes. We've done this for impressions. We're working on it for symptoms. But here's the parent code, kind of the 3-digit ICD-10 code. Here's the full code that was used. Here's the description. Here's the frequency count, and we just kind of color-coded these based on this key. So if there was over 3,000 EMS activations using this code, it's green. 1,000 yellow. 500 or less is red. So as you look through this, you can see the counts, and then you can see the frequency. And then over here, we built a priori a list of suggested codes for cause of injury, and you can see how many times those suggested codes were used versus where someone walked outside of that list and used another code, right? So the suggested list code, I'm not sure of the exact count. I'd say there's probably 50 to 60 codes there, and so you can see when you compare that to 1,700, it's sparse. If we limit this, let me try to limit this to just filter on the high value. So here's the codes that were used the most in 2017, and you can see that our suggested list wasn't too bad, right? So we've captured most of these. Clearly, the suggested list could be modified based on what we're seeing in this data. So that's really the 2 ideas that are under consideration right now. Is still collecting the data as it's currently described and used under 3.4. And just after the data is collected, maybe collapsing it into these parent codes. And so there will be, several hundred codes versus 1,700 codes. Or trying to increase the precision of the suggested lists and using that, and a combination of using both. So that's also on the table. All right, so I hear a phone ringing. Okay, all right. So that is where we stand in regards to dealing with this really large amount of data that's now coming in, just based on us using these code sets that are associated with becoming a national standard here in the U.S. So that is really the presentation I had. So in summary, I'm feeling pretty good, I think, about our ability when we have moved to version 3 to address these four issues that we tried to make forefront in the revision from 2 to 3. I think our data quality is greatly improved. We'll continue to do further deep dives, right? I mean, it would be really valuable, for example, to do a deep dive on cardiac arrests and look at the logical progression through those data elements, right? We have lots of information about a cardiac arrest, and it should all be reasonable. It should all be rational. And so we can work through kind of different scenarios and look at the quality of the data based on a scenario. So those kind of deep dives will be accomplished, I think, over the next many months as we now have, a version, a public release version of the V3 data available. Enhanced provider performance. We're incredibly excited about the benchmarking possibilities that are available with the API. That will clearly be helpful. Hopefully in your states, you're seeing examples of where this data quality is enhancing your ability to look at real-time small cell performance. The automated transfer of data, I think it's looking good. If really our data is coming in 2 to 4 days, that's really good. We'd love to have it continue to drop, and I think it will. The underlying architecture is present to do that. And then, of course, we need to resolve some of these issues associated with the clinical content. I can't speak to the precision of the additional codes. Clearly, they're more specific. The volume becomes difficult to use, and we have to figure out how to maybe collapse this real specific detail up into larger groups, and we'll work on that. But I'll stop there and ask if there are any other questions related to the 2017 data set, or what I hoped to also cover is talking about the enhancements that come with version 3. Any questions related to either of those two topics? All right. Okay. Well, as always, if you have questions about the data, if you're interested in using the 2017 data, we're clearly working with folks to get them ready to receive the data set. As I mentioned, it should be available shortly. Would love to make it available to your stakeholders at the state level or at the agency levels, or researchers who would like to utilize that data. We have a V3 cube that's very similar to the V2 cube that's under development, and Lisa and the IT team here have made great strides in that. That should be out by the new year as well. That will just have 2017 data in it, and as we move forward, we'll add additional years to that tool. But it will be much more specific. It will include U.S. Census data, so you can look at differences in different types of communities, the type of care they're receiving. So it will, I think, be a very popular tool. So if there are no more questions, thank you very much for joining us today. If you have any questions, feel free to give me a call or to contact the NEMSIS TAC just through the NEMSIS.org website. All of our contact information was there. And if you have no other questions, enjoy your Thanksgiving holiday. Thanks for joining.